Maybe when you admit everyone, we can just allow 5 minutes more before we proceed.
Yeah.
Linda, what is your screen?
Pardon me?
Your screen. We need to see your screen with the introduction slides ready.
The introduction slide. Can you see?
Okay, we are going live. That's so everybody knows, so that we are mindful of what we say.
Preeclampsia, hypertension and pregnancy. When you get to 50 minutes.
We are 50.
Hypertension in pregnancy.
Start. A very good evening to you all, and a warm welcome to you all as well. I am Dr. Linda Fonjo, and I'm with the Department of Molecular Medicine at the School of Medicine and Dentistry, KNUST. And I'm also a member of APEC Ghana, and I'll be your moderator for today's webinar. And so on behalf of the executive body and the organizing team, I warmly welcome you to the second APEC and Sports Studies webinar series on the management of hypertension in pregnancy. Hypertension in pregnancy continues to be one of the leading causes of maternal and neonatal mortality in Ghana. And indeed, the executive director of APEC is a preeclampsia survivor. And she has shared her survival story on several platforms, including the Joy Hotline documentary. APEC Ghana is the only preeclampsia working advocacy foundation in Ghana, and it's aimed at creating awareness and reducing infant mortality and maternal mortality caused by preeclampsia through education, research, and support. Sports Studies is an international research group based in the Netherlands and at the Greater Accra Regional Hospital, and they happen to be our international partners. And the aim of the Sports Studies is to improve the quality of care for women with preeclampsia and other hypertensive disorders of pregnancy in Ghana through interdisciplinary research. On the 31st of July this year, we had our first webinar series on the topic, Management of Hypertension, Prediction and Management During Pregnancy. Today, we are delving into management of hypertension, delivery, and postpartum. The objective of this webinar series is to increase practitioners' awareness on hypertensive disorders of pregnancy and to provide practical knowledge about the management of hypertensive disorders of pregnancy. We have two distinguished specialists who will be introduced very shortly, and they would help us navigate and understand how to manage hypertensive disorders of pregnancy from delivery through to the postpartum period. I'll then treat you all to type your questions in the chat section, and we'll let our speakers address them when the time is due. Ladies and gentlemen, I have the singular honor of inviting Dr. Mrs. Vivian Boama, who is a senior lecturer at the Department of Pharmaceutics, KNUST, to introduce our speakers. Dr. Boama, the floor is yours. Thank you.
Thank you very much, Linda.
Hello, everyone. It's good to have you on board. You're most welcome to today's webinar. As our facilitator already said, today we listen to speakers who talk to us more about what APEC Ghana is passionate about, saving lives of mothers and lives of children. For our speakers today, we have Dr. Charles John Bachman, who is an obs-and-gynae specialist with the 37 Military Hospital in Accra. He had his university education at the University of Ghana Medical School. He has a postgraduate diploma from the School of Tropical Medicine in the UK. He's a fellow of the West African College of Surgeons. and currently is a senior specialist at the 37 Military Hospital Obs and Gynae Department. He's also the CEO of Back Specialist Hospital and Fertility Center in Accra. He's a clinical tutor and a lecturer at the Accra College of Medicine. His research interests include BMI, maternal BMI, maternal body mass index, and the risk of hypertension disorders and diseases in pregnancy. He's interested in preeclampsia and heterotopic pregnancies. For today, he would be talking to us on the topic, management of hypertensive diseases in pregnancy, antenatal care, and during labor. Our second speaker for the day is Dr. Kwame Edu Bonsafo. He's a lecturer at the Department of Obs and Gynae at the University of Ghana Medical School, Legon, and a consultant at the Kolebu Teaching Hospital. Dr. Edu Bonsafo graduated from the University of Ghana Medical School and completed his postgraduate training in Obs and Gynae at the Kolebu Teaching Hospital in Accra. He has an MPhil from the University of Ghana Graduate School and is a member of the Ghana College of Surgeons and Physicians, and also a fellow of the West African College of Surgeons. He has extensive clinical and research experience and research interest in maternal and fetal medicine, management of hypertensive disorders in pregnancy, maternal fetal medicine, preeclampsia, preterm birth, and reproductive endocrine physiology. Today, he'll be throwing more light on management of hypertensive diseases during caesarean delivery, on preeclampsia, on eclampsia management, and postnatal management of eclampsia. I welcome our speakers to today's session, and it promises to be a very interesting one. Thank you for joining us.
And so now we'll call on our first speaker, Dr. Bachman, to please share your slide. The audience awaits you. Thank you.
Okay, thank you for inviting me. Okay, so we are talking about hypertensive disease in pregnancy, antenatal care, and then through labor. Hypertensive disease in pregnancy, as we are all aware, is quite an important topical issue because of its association with maternal mortality. All over the world, some couples will try to get pregnant and then await a baby joyfully, but in some situations it ends up with grief. So, and in worldwide, one of the major causes of maternal mortality is hypertensive disease in pregnancy. It's one of the top 4 causes, and certainly in Ghana, it's also one of the top 4 causes. And a recent study, I think in 2014, by my colleague Kwame Edu Bonsafo showed that it was the leading cause of maternal mortality in Kolebu Teaching Hospital. And then another senior colleague in Tamale also showed that it was the leading cause in Tamale Teaching Hospital. So it's quite an important topic to discuss. globally, we have about 295,000 women who died in 2017, and the large chunk, about 86%, were from Sub-Saharan Africa and Southern Asia. And then Sub-Saharan Africa accounted for about 195,000. And out of this 195,000, a large chunk is in pregnancy. In Ghana, our maternal mortality as at 2017 was 308 per 100,000 live births. And in 2017. So when we compare to the previous years, in 2013 was actually 308, and it's gone down to 211 per 100,000 live births. Let me say it again. In Ghana, maternal mortality as in 2017 was 308 per 100,000 live births, to the global average of, according to the WHO, of 211. We are still quite high when compared to the worldwide average. So a lot of effort needs to be done. It has certainly reduced compared to previous years, but still more work has to be done to bring it further down. Okay, I'll leave this slide. I did a study at 37 for my postgraduate training, and it showed, this is in 2016, was published in the Postgraduate Medical Journal of Ghana, and it showed the overall prevalence of hypertensive disease in pregnancy as 11.79%. And the prevalence of preeclampsia was 5.12%, which corresponds to the worldwide prevalence of about 10%. So it means all the various centers are is still one of the leading causes of maternal morbidity in Ghana. So I've talked about this already. Now, so the scope of this presentation, we'll talk about classification of hypertensive disease in pregnancy. We'll broach pathophysiology a bit just to help us understand the management. We'll talk about risk factors, and then we'll go to the management. Okay. So according to the International Study of International Society for the Study of Hypertensive Disease in Pregnancy, it's been divided into two: hypertension that develops before 20 weeks, and then one that develops after 20 weeks. One before 20 weeks is chronic hypertension, as we are all aware. But then we have a few which has been itemized as well. White coat hypertension, whereby before 20 weeks, if you have a patient who comes in and then just by seeing the sphygmomanometer, the BP starts going up. When she's at home, the BP is fine. It's been noted that sometimes when you give, if nurses check the BPs rather, the BP doesn't go up that much compared to when a doctor checks. So when you have such issues, let the nurses check rather. But certainly, once you have white coat hypertension, it's one of the risk factors for the development of preeclampsia later on in the pregnancy. There's this other one of marked hypertension where the BP is fine when she comes to hospital, but when she is not in hospital, the BP is up. So with this, you will only know when you do ambulatory BP monitoring or automated blood pressure monitoring at home. Then you'll be able to pick this up. This will really come up when there's a mismatch. Let's say the laboratory findings of, let's say, acute kidney injury, maybe some liver dysfunction in the laboratory findings, but when you check the blood pressure is fine. So then you may be dealing with max hypertension, which is telling on the laboratory investigations. So if you have such a patient, then you should think about max hypertension and then ask her to do BP monitoring at home, and then you compare. It might bring it out. And then BP that arises de novo, as in starts after 20 weeks. Then we are dealing with gestational hypertension, and preeclampsia. And then worst case scenario will be when she fits, being eclampsia. According to the International Society for Hypertensive Disease in Pregnancy, proteinuria is not a mandatory diagnosis for preeclampsia. So that if, let's say, your BP is high and you have end organ damage. That's also termed as preeclampsia. So it's either hypertensive disease in pregnancy plus end proteinuria or end organ damage. So the end organ damage would be acute kidney injury, liver dysfunction, and some neurological features. One other important part is when you have hematologic features as well, with hemolysis or thrombocytopenia. If there's also fetal growth restriction, whereby we'll talk about it, it will also qualify as preeclampsia. Now there's some mismatch. Some of the societies, American College of Obstetricians and Gynecologists, doesn't agree with the terminology severe preeclampsia and mild preeclampsia, which has been suggested by the International Society for Hypertensive Disease in Pregnancy. And indeed, most studies have or most authorities divide it into severe preeclampsia and mild preeclampsia. ACOG doesn't agree because they think that you can easily tilt from mild to severe. So at any time. So if you rather treat it as preeclampsia with maybe hematologic complications or with fetal growth restriction, it's better to manage it that way than term it as mild and severe. So that if someone is termed as mild preeclampsia, she can easily be overlooked when indeed the problem is keeps going on in utero. So we'll talk a bit about the pathophysiology. I have to rush because it's quite a lot of slides. As we all know, blood pressure is cardiac output times peripheral resistance. In a normal pregnancy, the cardiac output increases by about 30 to 50%, and the peripheral resistance reduces by about 25%. But in gestational hypertension and preeclampsia, you have the peripheral resistance rather increasing. And so rather than having usually before 20 weeks, from let's say 13 to 20 weeks, naturally the blood pressure reduces and then starts rising up to its pre-pregnancy levels after 20 weeks. But with people with preeclampsia, rather the blood pressure will start to rise after 20 weeks because of the increase in peripheral resistance associated with their cardiovascular system. Some endocrine complications as well in preeclampsia are that usually in normal pregnancy you have some refractoriness to the angiotensin II hormones, vasopressin and catecholamines, so that the vessels will not be abnormally sensitive to them in normal pregnancy. So even though the levels of these hormones are high in pregnancy, you will not have vasoconstriction, or the blood vessels will not become smaller. But with people with preeclampsia, you have an increased sensitivity. So they rather have increased peripheral resistance because of the increased vasoconstriction due to the increased sensitivity to these hormones. Other endocrine factors are thromboxane and prostacyclin. In preeclampsia, due to some of these problems that they have, you have the damage to the endothelium, or the lining of the blood vessel. Now, these two hormones, thromboxane and prostacyclin, thromboxane will cause platelet aggregation and then vasoconstriction, while prostacyclin will cause will prevent platelet aggregation and then lead to vasodilatation. But in preeclampsia, you have more of thromboxane, which is the opposite in normal pregnancy. So you are going to have more vasoconstriction and then increased peripheral resistance once again, leading to your blood pressure going up. As I mentioned, the peripheral resistance times your cardiac output will lead to your blood pressure. In the hematology system, naturally there's a 50% increase in total blood volume. So you are going to have a physiologic anemia, whereby there's usually it's from plasma. So you have more plasma than red blood cell volume. And so there's a physiologic anemia. But in gestational hypertension, the increase is just 16%. So with this, you have some sort of some sort of hemoconcentration. So if you have vasospasm or vasoconstriction as well as hemoconcentration, then if you are giving such a person fluid therapy, it's very tricky. You have to be very careful. Otherwise, you send the person into pulmonary edema. There's renal perfusion is reduced in people with preeclampsia and gestational hypertension by about 20%. And so you have reduced urine output. So all this will tell. And that is how come with this reduced urine output, you have the uric acid building up in the system. This is because naturally you are going to, the GFR will, because it increases, will allow your uric acid to be excreted. But because in preeclampsia you have a reduction in renal perfusion and GFR also reduces, then you have uric acid and other and creatinine building up in the system. All right. So the other issue is with the liver. You can have some hemorrhagic necrosis affecting the liver parenchyma. It usually occurs close to the capsule or the lining of the liver. And so when these hematomas increase, it can actually even rupture, and the person will have severe epigastric pain. Worst case scenario, she may even need surgery. All right, so the other main pathophysiologic feature is to do with the trophoblastic invasion of the spiral arteries. I'll have this picture to show. So you have this up here is the vestigial lining of the endometrium, and then here is the myometrium. So with in the first wave of trophoblastic invasion, you have trophoblastic cells invading the spiral arteries. So these will become much bigger, and then the second wave, it moves into the spiral arteries within the myometrium here. In preeclampsia, this doesn't happen. The second wave doesn't happen. So you still have the vessels within the myometrium still constricted. So instead of the spiral arteries being converted from small capacitance and high resistance to low resistance, high capacitance vessels, which will improve blood supply to the placental bed, rather it becomes constricted because that second wave of trophoblastic invasion doesn't happen. So with this, then you are going to have problems with placental perfusion, and then you can end up with the baby being growth restricted. So all these are the reasons why like we have the clinical presentations of preeclampsia. So now that we are done with the pathophysiology, we'll talk about a few risk factors. So prior preeclampsia, chronic hypertension, multiple pregnancy is one of the big risk factors for preeclampsia. If the person has a pregestational diabetes mellitus, a BMI greater than 30, and some of these connective tissue diseases like SLE are risk factors for hypertensive disease in pregnancy. Now, assisted reproductive technology, like if somebody had a pregnancy through in vitro fertilization, is one of the risk factors for the development of hypertensive disease in pregnancy. And one of the main reasons is also because most of the women who come for ART are usually in the age range that is susceptible to hypertensive disease in pregnancy, certainly above 35. So other risk factors, as I've already mentioned, are advanced maternal age, family history of preeclampsia. And one interesting one is the short duration of a sexual relationship before pregnancy. So studies have showed that if a couple live together for longer than 6 months, their risk of, before they get pregnancy happens, their risk of preeclampsia development is much lower than somebody who got pregnant within the first 6 months of meeting their partner and having coitus. Yeah, and then the other one is paternity, where it has been shown that if the partner, the male, if you change it, let's say you have pregnancy, you got preeclampsia, and then you have a pregnancy for another man, you still have an increased chance of preeclampsia. But if it is the same man, then the chance of preeclampsia reduces in your second pregnancy. So paternity is one of the risk factors for hypertensive disease in pregnancy. Now, so the goals of management: one, to prevent convulsions. That is the main thing. And then to prevent complications. If you don't want your BP going too high to lead to a cerebrovascular accident, or pulmonary edema, or renal failure, abruptio placenta, or fetal death. And then you want to deliver a surviving child with minimal trauma to the mother. Okay, so as we've already talked about, I mentioned chronic hypertension, marked hypertension as one, and then the other being gestational hypertension, preeclampsia, and eclampsia. Now, with chronic hypertension, the essential hypertension accounts for the large chunk of chronic hypertension, about 90%. So secondary hypertension from, let's say, glomerulonephritis, or in the other, or pheochromocytoma, all the other endocrinologic causes of secondary hypertension, just accounts for about 10%. The large chunk is from essential hypertension, which is usually familial. So usually authorities don't recommend checking for secondary cause of hypertension if the person presents with chronic hypertension, unless the history brings out any such thing, right? So for the first diagnosis, once you diagnose chronic hypertension, these are the investigations that you need to do, because as we mentioned, a full blood count will help. Usually they are susceptible to hemoconcentration, so you may have your HB going up if it is there's a development of hypertensive disease, preeclampsia superimposed on it. You may have platelets reducing with thrombocytopenia. Liver function tests are also important to know if it's affecting the liver. BU creatinine and uric acid also give you an idea. You do a urinalysis to give you an idea about your urine proteins. Urine proteins is not, as I mentioned, is not used to diagnose preeclampsia. If it is there, it is part, but it is not a definite requirement to diagnose preeclampsia, right? And then if the person has a long-standing chronic hypertension, as in was hypertensive before she got pregnant and you were aware, then an echocardiogram may be useful to find out if the heart is in good order. Yeah. So all these can be done. ECG, if the person develops superimposed preeclampsia, then we may have to do some of the causes that can predispose to superimposed preeclampsia. So you have to rule out lupus anticoagulants and all these. And then for the fetal evaluation, we will need to do an ultrasound, whereby we'll find out the Lycor volume, which is one of the main prognostic factors. Lycor volume, and then Doppler ultrasound to find out about the blood vessel and the blood supply through the umbilical artery. A CTG is also useful. Now, so with somebody with chronic hypertension, the main thing is if you notice it during antenatal, you have to change the medications to be pregnancy compliant. So if the person is on lisinopril, you have to change to others which are pregnancy compliant, which we will talk about. Nifedipine, Labetalol are one of those that can be used. Studies, Sibai and colleagues recommend the discontinuation of all antihypertensives for all low-risk women with chronic hypertension. Because it's been shown that only half will eventually need antihypertensives. So if you find somebody with low risk, BP 140/90, chronic hypertensive, less than 20 weeks, you can actually put them off medication and then just wait. But then it means such a patient has to be followed up more frequently. You have to do see her more frequently than you would somebody who has a normal pregnancy. And then in labor, our goal is to prevent acute maternal and fetal complications. We'll talk about it as we go. So if the person comes and you need to admit, let's say has some sort of about your fluid use of IV fluids, because as I mentioned, the urine output is already reduced with hypertensive disease in pregnancy, and then also your GFR and the renal blood flow is all reduced. So you need to be very judicious with IV fluids. It's recommended that you don't give more than 2.5 liters in 24 hours. And then whilst giving IV fluids, SpO2 should be measured, so that if you're having SpO2 less than 90% whilst giving it, then you should be worried of pulmonary edema. Yeah, so let me move on. So then I'll talk about preeclampsia. Now, as I already mentioned, preeclampsia is the de novo onset of hypertensive disease, hypertension in the second half of pregnancy after 20 weeks, whereby you may have proteinuria and or the other maternal organ dysfunctions like acute kidney injury, liver dysfunction, and then neurological complications. You can end up with an eclampsia where they affect altered mental status, blindness, stroke, severe headaches, and persistent visual scotomas. I actually had a patient who had transient blindness, and then after delivery, after 2 or 3 days, we got the ophthalmologist to come and do fundoscopy, and then it was, I think, it wasn't retinal detachment, so they kept monitoring, and eventually she came back to normal. So you may have such situations. In worst case scenarios, you could have permanent blindness resulting out of preeclampsia. Hematologic complications, as I already mentioned, thrombocytopenia, and then DIC. So if there's severe uteroplacental dysfunction, where there's restriction of blood supply to the fetal placental bed, then it will show with abnormal umbilical artery Doppler, whereby you may have reduced end-diastolic blood flow or absence, and worst case scenario, reversed end-diastolic blood flow. And when this happens, then you need to work together with the maternal and fetal medicine specialist to help you navigate your way around. So I want to talk a little bit about the proteinuria. Here in Ghana, we usually use dipstick, whereby +1, we say if it's more than +1, then it's significant proteinuria. So if you have 1 gram per deciliter or more than 1 gram per deciliter, then you say it's significant proteinuria. Research has shown that, and is being used elsewhere, that a sports protein creatinine ratio is a better prognostic factor than just the dipstick, urine dipstick. That's because, you know, the urine creatinine is constant, whether in pregnancy or outside pregnancy, because it depends on the maternal muscle mass. So the creatinine, urine creatinine excretion is constant. So if you have increased urine protein creatinine ratio, then it tells you that there's something bad going on. So if you have a urine protein creatinine ratio more than 30 milligram per millimole, then it's abnormal. So so I've talked about all this. So I've talked about the controversy as well between ISSHP and ACO. Now, so we have about 25% of women with chronic hypertension developing superimposed preeclampsia, and it's higher in women with underlying renal conditions. So if you have a rise in BP in the first half of pregnancy, it may not be sufficient to diagnose superimposed preeclampsia. You have to wait a bit to see if you have other components, whether proteinuria or the end organ dysfunction. Okay, so I'll skip this slide. Okay, so women with preeclampsia should all be assessed in hospital when first diagnosed. So there was this way back in 2018 that a lot of maternal mortality was due to hypertensive disease in pregnancy. And so I think it was spearheaded by the regional director, Dr. Linda Vanotu, whereby a protocol was developed. And it's part of the learning resources which has been uploaded on the Preeclampsia page, the APEC page. And the main idea is that wherever the person is diagnosed, whether it's at a maternity home, primary healthcare facility, secondary or tertiary, the person has to be managed before the person is referred. So that if it's at a maternity home, the midwife should be empowered to be able to have nifedipine available, so that if the BP is high, instead of referring straight away, she will actually start medication before referring, so that the outcomes will be better, in the sense that by the time the person gets to a referral facility, she has already started being managed. So this is one of the reasons why I said whenever the hypertension is diagnosed, the person has to be first admitted, and then investigations done to categorize her now, whether to mild or severe. And then if it's mild, then we can send the person home, come for regular reviews on medication. But if it's severe, then you need to manage accordingly. So as I already mentioned, mild preeclampsia would be just the blood pressure between 140, 90 and 160, 110 with no symptoms. And then the severe will be more than 160, 110 with proteinuria and end organ damage, or with the fetus being compromised, as we've already talked about. Now, so our target diastolic BP in the management of preeclampsia, it shouldn't be too low. If you are managing preeclampsia and your BPs are around 110/70 or 120/70, they are too low. It will actually compromise blood supply to the fetal-placental unit and could eventually lead to growth restriction. So your target should be between 140 and 150, that's systolic, and then diastolic around 85. This is supported by International Society for the Study of Hypertensive Disease in Pregnancy. The agents are oral methyl dopa, labetalol, and then nifedipine. I'll talk about these agents. Labetalol, however, is one of the old antihypertensives which we all know. Just that its onset of action is it takes a long time for its onset of action, so it's not the preferred now. Okay, so I'll mention these. And now, so for once the diagnosis is made and you think that the person is mild preeclampsia, then you have to do expectant management. So with this, I'm going to do maternal monitoring and then fetal monitoring. So maternal monitoring, you are doing your BP monitoring, you assess proteinuria frequently, and then you do your blood test to rule out liver function, liver dysfunction, then the kidney dysfunction as well. And then fetal monitoring will be to assess the fetal biometry, to fetal weight, amniotic fluid volume, and the Doppler studies as well. And then for expectant management or expectant monitoring, twice weekly amniotic fluid assessment is useful. But estimating the fetal weight is not too useful within a week. Usually it's better 2 weekly. Yeah, but if there's severe growth restriction, then you can do assess it weekly. Somebody with severe preeclampsia will need magnesium sulfate for convulsion prophylaxis. My colleague, Dr. Edison Bonsafo, will talk about eclampsia and then the use of magnesium sulfate. So now I'll just give a gist about these antihypertensives. I'll just move straight here. It's been noted that Labetalol is a mixed alpha and beta adrenergic antagonist. It gives a very smooth BP reduction and has a rapid onset of action and steady maturation in preterm pregnancies. So, and it also increases the uteroplacental perfusion and decreases uterine vascular resistance. So I would say it's the go-to drug as a first line for your patients. But nifedipine is being used here in the Ghana Health Service more because it's been noted that if the blood pressure is normal, let's say the person is given at a maternity home because the midwife thought the BP was high, and the person is actually normotensive, the blood pressure, it will not compromise, it will not significantly reduce the blood pressure much. That's the good thing about nifedipine. That's how come it's being used as a first line. But in the tertiary centers, I think Labetalol will probably be a better first line because of the good parts that I've talked about. Okay, so so hydralazine is usually for used as an emergency medication together with plain nifedipine or rapid release with nifedipine. So the hydralazine is centrally acting vasodilator, and it increases your heart rate and cardiac output. So if you're using hydralazine, care has to be taken. It's better to preload, let's say with about 500 mils of crystalloid before you start hydralazine treatment. This is because hydralazine can lead to an abrupt reduction in your blood pressure. So if you're not careful, you compromise the blood supply to the fetus. Okay. So these are the indications for max sulfates, and my colleague will talk about it. If there's severe preeclampsia with end organ damage manifestations, eclampsia, or your BP more than 160, 110 in labor. And then it's also used for fetal neuroprotection in preterms. It's been noted that if it's given for a preterm delivery before 34 weeks, there's a reduced chance of the baby developing cerebral palsy in later life. So it's neuroprotective there as well. Yeah. So, but a note of caution is that a lot of studies, Jenkins study that I came up shows that if you have severe preeclampsia developing before 25 weeks, waiting will not be too helpful because just about 10% will survive. And then those who survive to have severe handicaps. So you are better off the person having some psychological support and then delivering. Because if you wait for too long, you will have a poor outcome. So we'll come to delivery. Women with preeclampsia should be delivered once they reach 37 weeks. And this was corroborated by the protocols that I mentioned, developed by the Ghana Health Service. This is from the International Society for Study of Hypertensive Disease in Pregnancy. So please, beyond 37 weeks is not useful. If you need to give steroids to mature your lungs, just do and deliver. Once you have preeclampsia or gestational hypertension at 37 weeks, you're better off delivering. Waiting would not help. And then repeated episodes of severe hypertension, despite giving maximum doses of at least 3, some say 2 classes, other studies say 3 classes. At 37, if you give maximum dose of 2 antihypertensives and the blood pressure is not reducing, then it's an indication for delivery. And then progressive thrombocytopenia or abnormal renal or liver enzyme tests. pulmonary edema, not because of fluid given IV fluids, but as in resulting from the preeclampsia, is an indication for delivery. And then if you have abnormal neurological features, which I talked about, the scotomas, transient blindness, or if she convulses, then certainly you have to deliver. So serum uric acid level is not, or proteinuria is not an indication for delivery. It is the clinical indications you would use, not the laboratory uric acid, which you say uric acid is very high and so needs to be delivered. You have to relate it to the clinical picture. All right. And then if you have a person who delivers preeclampsia at 37 weeks, there's no point waiting, you deliver. If you have between 34 and 37 and the person is stable, you can manage expectantly till 37 weeks and then you deliver. If you have a stable patient with preeclampsia less than 34, you manage till 34, and then if she's still stable, you can continue to 37. But if she gets to 34 weeks and you have issues either with the biochemical indicators or the fetal viability, then it's an indication for delivery. So psychological support is...
You should be rounding up now, please.
Okay, I'm almost done.
Thank you.
So our psychological support is very essential. I think it's one of the things that are left out in our health system. So we need there's clinical psychologists to be involved in their care. So I've talked about all these. So I'll just mention briefly that the protocol for in labor is that when a person comes in labor, we have this antenatal records book. You check to see if your blood pressure is high. You check to see the investigations that have been done, and then you are going to do your BP monitoring and control. You check your bedside clotting. I've just use this protocol as a mnemonic. So admit, assess the antenatal booklet, BP monitoring and control, bedside clotting, and blood products should be. You do your bedside clotting if whilst waiting for your formal clotting profile, and then make sure you have your blood products available in case you need to give, and then counseling for danger signs, which I've talked about, proteins, and if you have facility for urine, spot urine protein creatinine ratio, it will be preferable. And then you determine your delivery mode. SVD is preferable, but if your cervix is not adequate and it will take a long time, certainly more than 24 hours to deliver, cesarean section would probably be a better option for you. And then, as I mentioned, fluid management is very, very essential in labor. You don't give more than 2.5 liters of IV fluid. So I've mentioned all this already, and these are my references. Thank you.
Thank you very much, Dr. Bachman, for that in-depth and insightful presentation. We'll now call on Dr. Edubon-Safo to take us through the next presentation. Thank you.
Good evening. Please, can you hear me?
Yes, we can.
All right. First of all, I want to say a big thank you for the opportunity to present at this international meeting. So the title of my presentation, as you all have seen, we are supposed to talk about management of hypertensive disorders in pregnancy, and we are considering intrapartum aspects of the management and also the postpartum. And I will be talking about delivery aspect, which is cesarean and postpartum care. Dr. Bachman has already talked about the vaginal delivery aspect of it and some other aspects, including the pathophysiology. So the outline of my presentation will be as you can see. we will start with some introduction, which will not be too long, and then we'll go through timing of delivery, mode of delivery, and discuss some principles of management of postpartum hypertension and some antihypertensive. And then we can conclude and finish with a short case presentation. Of introduction, just to remind us that over the past 10 years, the proportion of maternal death due to hypertension in pregnancy has actually doubled. This can be the Maternal Health Survey 2017, which showed that in 2017, it was around 9%, and now it's about 18%. This is maternal aspect. If you compare the perinatal outcome, the neonatal outcome, though we are worried most about deaths, it occurs about less than 1% in severe preeclampsia, and about, if you compare perinatal death, which is about 30% in people with severe preeclampsia. When it comes to eclampsia, it's worse. Maternal and perinatal death is about 28. So even though we are worried about the maternal death, the perinatal deaths are even more scary. And most of it to substandard care, which has been detected. So you can see that most of the causes is basically due to preeclampsia and the complications associated with it. The rest can also cause some form of complication. I'm mostly afraid of the pre-complications. These are the other classifications which have been already by Dr. Bachman. So just to remind us that preeclampsia can affect all or complicate all the systems. And so whenever we have a patient in front of us, we should not think about only the BP. We should look at all the possible complications that may occur. And that will let you identify the complication early and solve it. That will also help us to kind of reduce the morbidity associated with the condition. And so if you look at it in a study that we did some time ago, that actually these are some of the complications that led to maternal death. And you hear that even pulmonary excessive fluid infusion was very significant. It was about a third or fourth cause of the fourth cause exclude, and acute renal failure and CVA also constituted significant causes of death. So you see, this is the slide you see is let's say the backbone of a study was mentioned by the that when she was introducing, we realized that most of the causes of death are due to the severe forms of the disease and those who develop the disease in early pregnancy. Let's say that means we are talking about less than 28 or 26 weeks of gestation. And if you look at it, you realize that about 25% of preeclampsia is actually remote from term. That means that this is the ones we are talking about. And so this study, we want to look at how we can predict adverse outcome among women who present with preeclampsia of remote onset. And so you can see that it's a validation study. So we are trying to look at clinical factors, for instance, like parity, gestational age at the time of admission, whether there's headache or visual disturbances, chest pain, and others, including laboratory tests to see. This was a study that was done in the developed world by Beth Payne and co, and it has been recognized universally. However, we thought of validating it in our environment and to see if it could help us in future. And it is ongoing, and very soon we will get the findings and probably share with our colleagues in Ghana here as well. So the reason is that if you're able to get to know which factors can affect or can increase the complications, then we can think about the timing of delivery. The thing is that timing of delivery or childbirth in people with preeclampsia is a very controversial issue. And because of that, more recent studies are showing that probably we should go back to the old system of teaching where we considered immediate delivery. Whenever you come and we diagnose you of severe preeclampsia, then immediate delivery is the option, especially after administration of magnesium sulfate. But as you and I know, currently, we are trying to manage some of these cases consecutively or expectantly. In that case, to try to mature the fetal lungs of the fetus, and if we end up losing the baby, and also mothers also having serious complications. So you have seen that in recent time, there's a growing interest in recommending immediate delivery. I mean, if you get somebody from 34 and it's a severe disease, you don't really want to delay so much. I mean, in order to protect the life of the mother. So expectant management is basically to achieve fetal lung maturity and also to prevent complications of the disease. And as you can see, there are no maternal benefits to expectant management. That means that it's only beneficial for the fetal lung development. And so for the mother, had it not been the psychological effect that the baby, I mean, we need both the baby and the mother, then at any time, any point in time, you can deliver the mother and the mother will be fine. So immediate delivery, Dr. Bachman mentioned some of the indications for delivery, and you can see that when you get to 37, there's no point to wait. But as I'm saying, currently, international societies are thinking about kind of bringing it down to 34, because there was a study that was done in somewhere in Uganda by Professor Shannon. He is a very renowned professor in the UK who has done a lot of studies in preeclampsia and descended to the sub-Saharan African area and also did some of these studies and the findings were that most of the women that were delivered even before 34 weeks, 32, 33, 31, we had a better perinatal outcome. The reason is that, as you can see, most of us are clinicians. We get somebody who is around 30 weeks, 32 weeks, or 33, and we decide to try some form of conservative management. And we end up either getting IUFD, that is intrauterine fetal death, or very bad asphyxia, and we lose them. However, if we deliver them early and we follow the immediate delivery, most of the time we admit these patients to NICU or neonatal intensive care unit, and sometimes we are able to get good outcome. So looking at it, Dr. Bachman has already talked about the natural delivery of the vaginal route of delivery. I want to look at the caesarean aspect. And caesarean, we could consider elective or emergency. Emergency caesarean section, if you want to define it, it has a lot of definitions. WHO has a definition that says that whenever you deliver somebody when she's in labor, then you consider that as an emergency. Otherwise, it is not really an emergency. However, if you look at somebody who has severe preeclampsia or eclampsia and you want to deliver as early as possible, maybe it may be also an emergency cesarean section or an urgent cesarean section, which can be done within 24 to 48 hours. So studies have shown that most of the people with preeclampsia who are delivered before 28 weeks, almost about 100% are delivered by cesarean section. But as gestation improves, then the cesarean rate actually goes down. So we see that the mode of delivery is actually determined by obstetric indication, not really the disease itself. And however, we have to acknowledge that whenever we have cases of fetal compromise, fetal distress, especially with preeclampsia, then we need to consider cesarean section, which is probably more beneficial compared to vaginal delivery. And optimizing time of delivery involves striking a balance, as I said, between the benefit and risk of prolongation of the pregnancy, especially taking the mother and then the fetus into consideration. And the fetus is the one that will always have problem. Mother is always free. So looking at this was a study that we did to kind of determine the mode of delivery and cesarean indications among women with hypertensive disorders. And you can see that about 45% of them actually delivered by cesarean section. That is total number. And then we had about vaginal delivery occurring in about 54%. So when these are the types of hypertensive disorders. We have about 57% delivering by cesarean section. And if you look at the emergency, as I mentioned, most of them were non-emergency. Non-emergency in this case, I'm referring to a definition where the woman was in labor, not the agency type of definition that I'm talking about. So we realized that only 18.5% actually in labor, and most of them were not in labor. Looking at indications for women who had as you can see that in our study, well, previous cesarean section complicated or kind of caused a lot of deliveries by cesarean, and then unfavorable about 22.6%. You can see here that distress also caused about 15%. This is significant. And thinking it's possible that those times, that was around 20, is associated with sudden reduction blood pressure from severe vasodilatation. And so this is a very significant factor. Cut failure to progress, which was about 10.5%, and placenta 5%, and others. Failed induction was actually also constituted about 7%. But then you can see from the table down here that we also had a lot of significant induction of labors occurring here, and we can see the success rate of 67%. And so it tells you that even in people with preeclampsia, you can see that significant amount, about 61 or 62%, actually was induction of labor. So there was a study, this is an international study that was done to actually decide on whether to do immediate delivery or prolong the pregnancy. It turned out that immediate induction of labor was associated with reduction the incidence of severe hypertension without increasing the cesarean rate. Conditions or let's say complications were about the same. And so it turns out that mentioned from the professor's study, although we had a lot of the neonates, the NICU was still very good. And so as we move on, probably we should be thinking about that. So when you have severe preeclampsia, as Dr. Buckman has described the definition of severe preeclampsia, we probably have to think about manage this patient. So admission is number one. We have to admit almost all of them. I remember that when we were in medical school those times, once you give magnesium sulfate, you have to deliver. But as I said, now things have changed a little. We give and observe for some time. And then also, we also know that it can also have some neuroprotection that has already been mentioned. But if you get a preeclampsia, severe preeclampsia, less than 26 weeks, we are not likely to achieve much. Therefore, maternal counseling is very important. 28 weeks going, you are likely to get a live birth or good outcome somehow, especially if steroids are given and then you are able to delay a little bit. But as we move on, we may have kind of think about immediate delivery for most of these women when they present with live birth between 28 to 34 weeks, and then in consultation with the pediatricians as well. Around 34 weeks and above, currently, if you have somebody with 34 weeks and above with severe preeclampsia, the current evidence is showing that we should not probably be thinking about waiting so much, because as we all know, 34 weeks, even though neonatal outcome we may have some form of neonatal respiratory distress syndrome, we probably will have to think about delivery. That was for severe preeclampsia. When you have eclampsia, then that is also a management plan is relatively different, but we can say that there's no time for you to wait. Eclampsia means delivery, as we all know. We can see that eclampsia occurs in about 50% in the antepartum period, 25% in the intrapartum period, and then 25% post. These two, that's about 50%, 50-50. And so we need to be very careful when we have eclampsia. And the treatment goals, first of all, you need to resuscitate the woman and stabilize the woman before we deliver. The problem we have, it might not be, it's not the stabilize first, so the BP and also the convulsions and that we talked about. And then think about, and also very careful with fluid balance, very careful with fluid balance, which we will talk about again. And then the safe delivery will depend on fact that once you have eclampsia, it means caesarean. No, you have to examine the cervix before you decide. Maybe she might be fully dilated, or the cervix may be favorable for you to achieve vaginal delivery. And we should always think about involving the other specialties, anesthesia, renal physicians, and the neonatologists, as well as the midwives. And the first aid, as I mentioned, is very important. First aid for somebody who is having eclamptic fits include trying to protect the person from injuring herself, and then secure airway, iftar oxygen, and then IV access. We realize that, I'm sure in some books it's mentioned that you put a spatula or a spoon or something in the mouth. That is dangerous because during spasms like that, most of the muscles are in spasm, and it will be difficult for you to, it's not really recommended. So the ABC is very important, securing access and then preventing further fits. Or for the current fit, maybe by the time you get your drugs, the fit is over. So it's really very difficult for you to prevent the ongoing fit unless the patient is having recurrent or status eclamptic, when the eclampsia is actually non-ceasing often. And we have to think about management in the high dependency units if available. In Kolebu Teaching Hospital, for example, most of our cases are managed at the recovery, where we have anesthetists cover and other critical care nurses around who can help with the management. Otherwise, we should manage these people in the high dependency unit or ICU if available. And we need to start parenteral antihypertensives, especially if you have that high blood pressure. However, let me mention here that mention Hydralazine, and in our part of the world, we should be thinking about nifedipine, because nifedipine can, however, if patient is not conscious, then it will be very difficult for you to give nifedipine. And fluid management is very important. However, we don't go more than 85 per hour or 1 ml per hour, because one of the main pathophysiology is the leaky capillaries that are part of the pathophysiology. All preeclamptics have leaky capillaries, and therefore they develop edema easily. So be very careful with that. Oxygen is very important, we not forget. And then intermittent monitoring the fetus, either continuous, if you have the continuous fetus monitoring around. Laboratory tests are very important. And as you can see, in our part of the world, we are, most of the time, we don't get opportunity to support us a lot, but time a patient report, and that is something we need to be working on. And continuous monitoring is essential and vital in these women. Really, you need to manage these women in their necessities will help neuromuscular paralysis and then ventilation. In some cases, to do neurological evaluation, including imaging, because some may have got CVA and other complications coming in. And as I mentioned earlier, there's a need to plan your delivery, but first do stabilization, to think about delivery within about 6 to 8 hours. You think about caesarean and to like caesarean delivery. What do you do? First of all, if and we'll talk about or spinal. However, if you have other complications like low platelet, less than, let's say, 80, that is not too good. You don't have to think about epidural or this regional, or there's DIC, and there are other control of the needle and all that. We need to be careful with that. Prevention of the eclampsia, magnesium sulfate is very important. And in Ghana, we most of the time use regime, which involves the IV magnesium sulfate by the maintenance dose. Span management, they will use, so we are comfortable with the use of this. But if in any situation, somebody wants to use the infusion, you can do that, and then you monitor the patient. But the most important thing is magnesium sulfate is it's a toxic drug, and you have to be very careful about that. I remember one day I was doing residency, and there was a patient who had severe preeclampsia, and after the surgery, she had surgery. And after, I think the next day, she had visitors who had visited her and then left. And the nurse was going to set up IV magnesium sulfate and set it up. And you can imagine quickly the woman died. And this is where you are getting a lot of recurrent eclampsia within a short while. After giving the loading dose, the patient still has can repeat the IV dose, maybe 2 grams start, and then you can now continue with your maintenance dosage. Because you definitely need the anesthesia people to come in to help with intubation and subsequent drugs. For I remember that those times in training, we sometimes struggling with magnesium salt this medication. However, whenever you are stressed, which you should not forget. So we have decided to do cesarean section, pre-operative management. What do? We need to make sure, as I said, it's not like to prepare the patient. It can be done, or regular meal. It is also acceptable, but the anesthesia will also help us in this direction. Or hydration is very important, but we got to be very careful. You have to live. We also have to conclude that the antihypertensive we have already mentioned in our part of the world, Philippines, having people with eclampsia Dexamethasone is very important in product as well because complications that might occur. We should definitely avoid egometrin, which will be mentioned again. So with the magnesium sulfate, we have to be monitoring the patient to make sure that they don't get anxiety, and you have to have the antidote available to help with that. Hydration, as I said, the motor is very good, but if the patient, there's a fetal compromise, then no anesthesia, which also carries some risk. You can have a risk of aspiration, failed intubation because of laryngeal edema, and you can also have CVA from a sudden increase in intracranial pressures from the intubation. And this is very important for us to know that actually it's still difficult to know, the ideal volume of blood of fluid to give, and even the type of or the specific type of fluid to give, whether to give normal saline and all that. There is still controversy. However, in terms of see that to manage, it's not very useful. BP is actually normally because volume contraction associated with preeclampsia. Using work pressure, pulmonary work pressure, could be very useful, but that is also more invasive and is difficult. And there's also a poor correlation between CVP and the pulmonary work pressure, and so it's difficult. The thing is that it is not really monitoring of people with severe preeclampsia unless there are other complications associated with it. If you want to give prehydration, as we mentioned, for anesthesia, regional anesthesia, you may give up to about 250 to 500. You don't need to give so much because it can cause a pulmonary edema, and the use of colloid is also, and then whether colloid or crystalloid is also something we need to be very careful about. Good. The patient has oliguria, then in the patient. Oliguria with positive fluid balance, that means that there's not a lot of deficit. Then you can give maybe you to challenge the system. However, if there is negative fluid balance, then you've got to be can repeat that, but you still have to be very careful giving those fluids. So in terms of other things that you have to consider, we may have to give antacid and also consider lateral tilt. May be done by the anesthesia team, and then we have to consider the level of platelet to decide on what to do, whether we need to do spinal or GA, and these are very important. We need to, and we should be careful about the use of boluses. It's not recommended. So cesarean section is not really very different, but we need to be very careful if you want to look at the incision to give. Most of the time, the midline will be very, especially if there's complication like DIC, you suspect that the patient might have low platelet and other bleeding, because splitting or stretching the muscles, you could have tearing, and this could lead to hematoma formation, which will not be good. Development of the is you can avoid that. I recommended in general that the more you dissect, the more you might into some form of vessels, and you can get hematoma also coming out. As bringing the uterus out and doing the suturing also something not recommended. If you can do that, you can reduce not cause so much disturbance, because if there are some adhesions, this can cause some form of hypertonia if you are not careful. Double layer closure is very important. Preeclampsia or severe preeclampsia. So even though we know that single layer closure of the uterus is done, in such patients we have to be very careful not to do if, for instance, closure, to be thinking about that, especially in patients with complicated preeclampsia. And subcutaneous should be closed. Active management of the third stage, I mean, in the cesarean is very important. We should consider oxytocin drip as well. Tranexamic acid is something that could be used if you are hot. Even though people think it might be clotting issues as well, but it's very important here. And induction of labor, this is a study that was done. Most of them also delivered vaginally. Shouldn't worry about ourselves about that. Immediate postpartum care is very important. Have had cesarean section, in vaginal delivery, straight monitoring of the BP is very important, or other vitals, including oxygen saturation, regular checking of the chest for pulmonary edema, and also fluid is very important. We should not forget continuation of the magnesium sulfate after delivery, and then thromboprophylaxis after 24 hours or 12 hours after delivery is also something we should not forget. Pregnancy itself is thrombogenic, and then preeclampsia makes it worse, and so we should not forget things like that. And our antihypertensive should also be continued. Postpartum hypertension or preeclampsia is something that is something we should not forget about. It's very important because obstetricians, as we are, most of the time after delivery, some people might think that they have achieved their aim. Especially, we need to be thinking about postpartum preeclampsia. And I can say that most of the cases of postpartum preeclampsia, about 50% of antenatal period, which is now transferred to the postnatal period. And I want to say here that in people with preeclampsia or gestational hypertension or whatever it is, they normally will get a drop in their BP within the first 48 hours. However, most of these problems of severe hypertension come between the third and the sixth day. So we have to be very mindful about the first 24, 48 hours that BPs may be fine or may go down, but we got to be very careful with that. And the commonest cause of postpartum hypertension is gestational hypertension and preeclampsia after delivery. This table shows us a list of the causes of postpartum preeclampsia or hypertension. And we should not forget about the hypertension I mentioned, volume overload, medications such as brufen, diclofenac, and the rest. We've got to be very careful because these can actually precipitate postpartum hypertension, and we need to look at that. Others are the secondary hypertension that Dr. Bachman mentioned, and we can look at that later. Then antihypertensives for women who have postpartum hypertension is also very important. In fact, there is no reliable data to guide whether antenatal antihypertensives should be continued postpartum. You cannot know easily. Even people with very high severe hypertension, they immediately after delivery, some of them actually have normal BPs and it continues. However, some of them may have even not too high level of the BP, but post-delivery, they get very high hypertension. So let's not think that somebody had mild preeclampsia and therefore we should, after delivery, the person will be fine. We have to be very careful about that. What drugs are very important in the management of people with postpartum preeclampsia? Actually, here we can use a lot more drugs than in antenatal period. Look, we can use labetalol, nifedipine, atenolol, metoprolol, and even in some cases amlodipine. Although you got to be very careful with that, with some of these things. I'm sure people will ask why mitadopa is very good in the antenatal period, but when immediately after delivery, we recommend that if you can switch, it will be better because mitadopa is associated with some complications which are not too good for the woman in the postpartum period. One of them is that they may get postpartum depression and other psychological issues. They can get severe sedation and all that. In the postpartum period, mitadopa could be relieved. And that can be done in a very nice way. Like, it's not a sudden thing. You can gradually do it in the transition phase. And we say that, in fact, WHO recommends that in women treated with antihypertensive drugs antenatally, we have to try and continue. Continuation is recommended. And then treatment with antihypertensive drugs is recommended for women with severe hypertension. Severe hypertension is the same as the 160, 110 that Dr. Bachman mentioned. But we need to be very careful that, in fact, in the postpartum period, things may get worse before they improve. We have to be very careful about that. And oliguria can occur within the first 24 hours, and we have to be very careful with fluid management. Seizure risk is greatest, that is after 48 hours, and we have to be very careful with that. And then we should not think about discharging them less than the third day after delivery. Then we need to continue with the management. Postpartum symptoms are similarly the same as the head visual symptoms that were mentioned. And so we have to be very careful. And we need to monitor those ones with severe preeclampsia for at least 5 days. There's no point rushing to discharge them, especially in our part of the world where we lack a lot of monitoring things and all that. And this diagram tells us about a way to go about managing postpartum preeclampsia or hypertension. First of all, if it's only hypertension alone, then you can decide to give your antihypertensive and observe the patient. If there's good response, then you don't need to do any further management. However, you may need to check for other causes if there's no response. And it goes through all that until you can see a situation where you have hypertension plus nausea, epigastric pain, and all that. This is tipping the patient into severe complications, and we've got to be very careful with that as well. Fluid management in the postpartum period is very critical, and it's a common complication that we have to be very careful of. And we have to be careful that they don't get AKI, because you can get sudden drop in the level of the urine, and then this can cause trouble. So oliguria is very important, and we need to be careful with the fluid that we give to these women. And we should be careful about diuretics. It can be given, but you have to be very careful in giving it, especially unless you are able to document that there's some form of pulmonary edema. Otherwise, you have to be very careful into AKI. In the antihypertensives, first of all, you have to think about labetalol and lifidipine, probably for us as a first-line drug, as hydralazine can cause severe hypotension somehow. And we can use these drugs, as I mentioned already. NSAIDs, brufen and diclofenac, that we always use after, we insert rectally. We got to be very careful. Can we change that? Or we can use IV paracetamol or rectal paracetamol. We have to be very careful about that. I've already mentioned the fact that metidopa is not too good in the postpartum period, and we need to be very mindful about that as well. Other complications, other drugs are the NSAIDs that I mentioned, ergot, which the point is made already. So after the first 6 weeks of postpartum, to see that the patient is fine, and then we got to be of that, and then that we might get problems with
Dr. Bonsafo, I think we are losing you.
We need to investigate them more because we haven't identified.
Prof, we are losing you, Dr. Bonsafo. If you could check your connection, please. Oops. All right, we are losing Prof, but I would like to. Okay, we can hear you now, but the line is sort of tripping.
Okay, I'm almost done.
All right, thank you.
Please, can you hear me now?
Yes, please.
Can you hear me?
Much
can you
better.
hear me? Okay, thank you. Thank you, sorry. I think it's the internet. So this are my last, but preeclampsia can occur. How we need to look at the risk factors. They are likely to have hypertension, ischemic heart disease, and stroke in future. And so these patients who develop preeclampsia, we need to refer them to see the physicians to help with the management. And so, as I said, this is my last but one slide. In trying to conclude, what I will say is that appropriate treatment of hypertension in pregnancy is essential to prevent maternal mortality and morbidities. And women with preeclampsia remain at risk of serious complications, which we mentioned already. The postpartum period is a time that we have to be very careful about, especially the first 72 hours. And then we know that from the third to sixth day is also very critical because that's when complications actually set in. And the good thing is that we have a wider choice of antihypertensives to select from and during the postnatal period. And you just have to know the pharmacology of some of them, and then you can pick one of them. This is a slide to just tell us about one of the things. This was a patient who was referred from one of our polyclinics, and my resident called me about this patient. When she came, she was a 24-year-old she was 34 weeks, and then she presented with some lower abdominal pain. So they thought she was in labor and referred to us. When she was referred, the patient had tense abdomen, very tender abdomen. And as we all can allude to, the diagnosis of placenta abruption was made, and I was informed. And I asked the resident to go ahead and deliver by caesarean section because the service was unfavorable and there was IUFD. Then I was called later that I have to come to theater. When I went, there was hemoperitoneum, but the resident said the uterus was intact. And he didn't know where the bleeding was coming from. And when I examined the woman, I realized that she has had a ruptured liver. And so just to tell us about the complication that can really occur, she had a ruptured liver, and we called the surgeons. We tried and tried. They couldn't do much. And the patient kind of died from severe bleeding from ruptured liver. And you can see that when you have a ruptured liver, the mortality could be very high, and that one you can't do much. And so this is what happened to that patient, unfortunately, and we lost her. So at this point, I'll stop here for us to have some questions and then comments. Thank you very much, and sorry for the interruption in the internet. Thank you.
Thank you very much, Dr. Edu Bonsafo, for that very insightful and eye-opening presentation. Now we'll take questions from our participants. We have a few questions that has come in already, and I'll try to read a few to you so that, and this goes to Dr. Bonsafo as well as Dr. Bachman. If you can clarify for our participants, says, the protocol used in my facility says we repeat the loading dose of 4-gram IV and 10-gram IV after a fit. So I'm a bit confused about the 2-gram IV earlier mentioned. So this participant needs a bit of clarity. If you could kindly do that for us.
All right, I'll start by saying that, well, it's true. You can give 4-gram or you can give 2-gram, but most of the time you got to be very careful with the state of the patient. I did not mention, but we all know that the loading dose can always be given. However, when it comes to the maintenance dose and subsequent dosage, you've got to be very careful to look for toxicity of the magnesium sulfate. I know about what he's talking about. It's not a must that you have to give the 4-gram start again. You look at it and you decide you can give the 4-gram or you can give 2-gram start, depending on the situation. So that is not too different from what we have said.
Okay, thank you very much. Someone also needs clarity and says a challenge observed when nifedipine is used at the periphery prior to referral is that there's a tendency by some midwives to give long-acting nifedipine preparations instead of short-acting preparations. This is not often stated in the referral notes, and this leads to delayed refractory hypotension, often after CS delivery, further worsening renal failure and pulmonary edema. I don't know if there's anything you want to add to this observation.
Yes, that is why I think the person who asked the question is right. But if you look at Rich Hospital, they have started using plain nifedipine actively as their main, as the first line of treatment. And so we need to embrace this idea and start kind of maybe teaching and also revising our protocols with our nurses, and then this can help. But of course, they know that even if you don't have a plain nifedipine, they can give the retard, and that's what they give. And when you have cesarean section as well, as our friend said, you might have lost some blood, and therefore you can get some hypertension. But in this case, you've also got to be very careful with giving fluid, otherwise you can get complications. So he's right. We need this and all go on as we move on. The reason why I like the nifedipine is that in our part of the world, Labetalol could be expensive, and sometimes in Kolebu even we don't get it. And so if we are waiting to get Labetalol or Hydralazine and you don't get, a patient is dying. Meanwhile, we have a cheaper nifedipine which we could use. So we all have to come in and help with the training, and then we can start using nifedipine to improve the management of hypertension in pregnancy.
All right, thank you. There's another question here. Dr. Bachman, if you could kindly take this for us. The person wants to know what determines which patients with gestational hypertension will require workup to rule out underlying renal conditions.
Okay, thanks for the question. So, as I mentioned, if 90% of chronic hypertension will be due to essential hypertension, but if in the history, the person has underlying, let's say, is a non-nephrotic syndrome patient, or has significant oliguria, or has some features like facial puffiness, significant edema in that early, before 20 weeks, then you would want to rule out that possibly we could be dealing with some renal condition like glomerulonephritis, nephrotic syndrome, or some form of chronic kidney disease. Yes, and then also if you in before the 20 weeks you have significant proteinuria, I think it will be useful to also rule out some underlying kidney condition. Thank you.
Thank you very much. Pearl, I realize your hand is raised. You can please go ahead and ask your question.
Okay, I have okay, so I have a patient who is 36 weeks and a par 36 weeks with a BP of 160, 110, urine protein is 1 plus, and we started Hydralazine. But with this presentation, I realized that they said we shouldn't be in a hurry to conduct cesarean section. So I am asking, should we keep the patient and then monitor and try to reduce the BP for her to attain 37 weeks before we cesarean section done?
Okay,
Hello.
yeah.
Okay,
Yeah, okay, Dr. Bachman.
I mean, you go ahead.
Oh,
I should go ahead.
Yeah, go
okay,
ahead.
So yeah, so I think that the clinical condition is what will determine if you can continue your expectant management or you'd have to deliver. So you need to do your laboratory, like the laboratory investigations will help. And as well as if you give, your BP is 160, 110, then you have to go, you said you are using hydralazine, right? You have to give a long-acting antihypertensive as well if you want to do expectant management for some time, and see if you add a long-acting and then your BP is still not reducing, or even with the IV hydralazine, your BP is not reducing, you can't continue the pregnancy. Between 36 weeks and 37 weeks, essentially, if your BP is not reducing, I will give steroids and deliver.
Okay, so thank you. Let me add my on to it. Between 36 and above, you don't need to really wait, because you see the study I showed you with the Habitat study is more beneficial. If you delay so much, you might get complication, because 36 weeks, the fetal weight may be very good, although pulmonary function may not be too bad. And so you should think about delivery. If you can't deliver, you can refer to a facility where they can help with the delivery. So we shouldn't keep them waiting too much.
Okay, thank you very much. There's another question here which I think goes to Dr. Bachman, and it says, on the risk factors, there was a point made about duration of sexual relationship. That point was not clear to me. So our participants need clarity on the duration of sexual relationship and how that can,
thank you.
Can serve as a risk factor. Yes, please.
Yeah. Okay, so I mentioned that paternity, or the first time, the paternity, as in the anytime you change the father of the baby, you have a higher risk of preeclampsia. The other thing is, if you live together, or as in the pregnancy happens less than 6 months, it means you've been exposed to the paternal antigen for less than 6 months, you have an increased chance of having preeclampsia compared to if exposure to the paternal antigen, being the semen, being more than 6 months. It gives a lower risk of developing preeclampsia. All this, it's more like an association, because studies have linked the two, but it's not like it means once you have less than 6 months, like cohabitation or sexual intercourse before pregnancy, you definitely get it. It's a risk factor, and it's more because of association. Please, I hope I'm clear. Hello.
Yeah, I think Dr. Bachman, you are clear.
Thank you very much. If anybody has a question, please feel free to ask.
Let me say that Dr. Diganus actually has put a comment here which we need to be very mindful about. She's reminding us about the fact that some people come with abruption, placental abruption, and with severe preeclampsia. Sometimes when they come, their BP is not too high, but they may come with shock. And so as we manage, we shouldn't be thinking that it's only the severe form that may result in abruption, but moderate form of BP elevations may also be associated with abruption. Abruption is a situation where the placenta separates before delivery of the child or the fetus. Thank you, Dr. Diganus, for this important comments.
Thank you very much. I'd like to remind everybody that, as advertised, our webinar is CPD accredited, and the link has been sent to you via email. And also in the chat section, you have the links for you to register if you need a certificate. And also we have a link in there in the chat for evaluation. Our speakers are still here. If there anybody who has more questions or need clarity, you are welcome to ask your question. There's a question also here that says, with a repeat dose of IV magnesium sulfate, as to whether to give 4 or 2 grams IV, does it depend on the weight of the patient you are dealing with or the severity of the situation at hand?
All right. This is a very important question. Sometimes the weight is very important though, but you know, sometimes they are volume contracted, and so the distribution of the magnesium sulfate itself may be a factor. So clinically, the best way for us to look at this is not the size, but there are clinical things like, first of all, of the loading dose, checking the reflexes of the patient, and then even the urine output, because the main complication will be respiratory failure, acute renal failure, heart failure, and all that. So if the patient respiration is getting reduced, respiration rate is getting reduced, like it gets to less than 12 cycles per minute, then you know that there's a problem with the magnesium sulfate. It is causing toxicity, because respiratory toxicity is the first to occur, and you have to be very careful about. Then at the same time, you have to be checking the reflexes. If the reflexes are becoming too dull, then or absent, then it tells you that you are also having severe, you are getting toxicity of the magnesium sulfate. And you don't have to wait until you get heart failure or cardiac arrest. If you did that, that means that you did not really monitor the patient well, to the extent that the patient get cardiac toxicity. And so what I would say is that basically it's clinical monitoring, although in the developed world, they can do serum levels of magnesium as they give it to frequently monitor. But for us, clinical monitoring is number one. I haven't really, in my practice, seen a patient that we monitor with serum magnesium sulfate and magnesium levels. And I think we should limit ourselves to the clinicals.
All right, thank you very much, Dr. Bonsafo. Lawrence, I see your hand is raised. Please go ahead and ask your question. Thank you.
Okay, thank you for the opportunity. I want to find out at what point do we start treating patients who come in with BP of 140/90 or BPs of 150/100. At what point do we start with the antihypertensive? Because I've realized that there are times when patients come in and the BP is 140/90. We start the antihypertensive, but other specialists are also of the view that when they come in and the BP is 150/100, that is when we start. So I just want to be sure about this. When do we start with the antihypertensives? Thank you.
Okay, I'll take this. So as we mentioned, hypertension is diagnosed when it's 140/90 or more. So, and in preeclampsia, the hypertension is just a symptom of an underlying condition going on. So, but in chronic hypertension, without preeclampsia, the hypertension you see is the underlying problem. So it depends on what you have. If it's 140/90 for a chronic hypertensive, I won't treat. I would observe and see. But if it's 140/90 for new, as in de novo, started after 20 weeks from like 110/70 and goes to 140/90, I'll start treating, but certainly with a low dose of some medication and observe, and then you do your clinical monitoring as well, as well as your laboratory investigations to find out. So the important thing is with preeclampsia, the BP is just is just telling you of what's going on underneath. So if it goes up, you have to start.
Okay. All right. Thank you.
Okay, so what I'll add to it is that, as you said, a lot of protocols are saying different things. But as Dr. Bachman has said, I think when you have anyone, even with about more than 140 going, you should think about giving some small dose, because especially in our part of the world where we cannot monitor them fully well, we should think about somehow how we can manage our patient. If we always try to follow the other world, sometimes we get frustrated. Although in their protocol, they think about 150, 100, but I think we should think about coming down. On the other hand, for the chronic hypertensives, most of the time, as you know, they're already on drugs, so you may not want to worry yourself much.
Okay, another question here has to do with cost, and it says, who does the screening for underlying conditions and how should this be done? I'm considering cost implications and others in resource-constrained environments.
Dr. Bachman, do you want to take this or I should go ahead?
Oh, go ahead.
Okay,
Go ahead.
cost, actually, the cost of management of hypertensive disorders is very huge. Recently, we asked women about the challenges they go through, and it will surprise you what they say. Unfortunately, some of them mentioned that they struggle so much, they are not able to pay for most of the drugs, and some of the investigations too are costly. And their main problem is that it's not covered by the National Health Insurance, even though we have an idea of free maternal delivery and all that. It tells you that the cost of all this medication and the treatment and investigation is very high. And in a typical world, we need to be repeating this lab test at least every 48 hours. And it can be very huge and it's not easy. So it's very difficult to, for the women, especially as we know that most of them may not be working or may not really, most of these people are in the low socioeconomic class and they are not able to purchase or pay for the drugs and also the investigations. So we need to, in future, as we move on, maybe almost all these investigations should be put under the National Health Insurance so we can freely manage them. Okay.
All right, thank you. There's another question here on MAG sulfate, and it says, please, is it a must to always complete MAG sulfate protocol after delivering a patient who needed MAG sulfate, or are there instances where you do not?
Okay, maybe I'll start and Dr. Bachman will add. Okay. The thing is that MAG sulfate, ideally for now, the standard protocol is that you start with a loading dose and you add extra 6 doses to complete the maintenance dose. However, there have been studies to show that even if you are able to give only the loading dose, it is associated with significant improvement and reduction in mortalities. And so we are not going to recommend that always give the loading dose and don't complete. We recommend that try and complete. But even if you are not able to complete and you give the loading dose, it is still useful, and we should not avoid giving the loading dose. And the loading dose can always be given irrespective of if the patient is unconscious or having renal failure or anything. To add to that, I can say that currently there's a study ongoing by Dr. Bayo and team in Kolebu Teaching Hospital that are trying to see if we can modify this traditional protocol that we use. So they are bringing up a modified protocol so that you don't have to give all the 6 doses or the maintenance dose. If the study turns out to be of very useful clinical addition, then maybe with time we might move from the traditional 24-hour treatment to a less or a shorter duration treatment for magnesium sulfate.
Okay, to add to what Dr. Wazafa has mentioned, yeah, so before you, as for the loading dose, as he mentioned, even if the person is somnolent, the loading dose is okay. Studies have shown that it will not compromise the health status of the woman. But the maintenance dose, you need to make sure that the respiratory rate at least is more than 14 breaths per minute, and then you have adequate urine output. So there are certain criteria to follow before you continue maintenance dose. If you don't have such, the respiratory rate is low, and then you have reduced urine output, and you give it, you are going to compromise the woman's life. So you need to be careful. Certainly, because we do all these clinical checks because we do not check magnesium sulfate levels. Elsewhere, where they check magnesium sulfate levels before it's given, then you can determine that it's reached the toxicity level, and so you don't continue the maintenance dose. But here, because we don't check, you use the clinical part and then determine who to give and who not to give. So it is not wholesale for everybody.
Thank you very much. There's another question here that says, or two questions actually. Is it the current recommendation that hypertensive disease identified for the first time during labor be managed as a full-blown gestational hypertension, or considered as transient and managed expectantly?
Okay, this is quite an interesting question. It's difficult to tell. It's like a chicken and egg situation. The labor pain could lead to increased blood pressure. But then, as you mentioned, if it is transient and repeated blood pressure checks, it reduces. Then you won't treat it as a full-blown preeclampsia. But once it's throughout the labor, it is sustained and even progressive, then you have to treat it as a full-blown preeclampsia. So it depends. If Dr. Bonsafo, do you have anything to say about this?
Yeah, what I'll say is that you are right. Sometimes you are very careful, but if you look at the classification I showed you, I think the other time I presented, the International Society is saying that once a patient now is treated, develop the hypertension, whatever time, and you treat it with antihypertensive, then you don't call it a transient gestational hypertension, you call it gestational hypertension. But if the BP rises a little and you don't treat it with any antihypertensive, then you say it's a transient gestational hypertension. So in this case, once you think it becomes so severe, you get whatever value and you think it's severe and you treat it, then you have to go through the whole thing and treat. Remember that we mentioned that gestational hypertension can start anytime and it may progress in the postnatal period, and you have to be very careful about that as well. So as Dr. Bachman said, if you treat it can be difficult to treat actually. And you cannot say you won't treat also, because if you joke, you might get a CVA and somebody will ask you questions. And so you've got to be very careful when you get cases like that. I think wherever you are, it may be better for you to treat. You wouldn't be far from wrong, because we know that the treatment, maybe if you give nifedipine can be given for people who have normotensive BP, especially for treatment of preterm birth or preterm labor. So if you are hot, you are in a district, it may be better for you to probably treat or give a dose and observe and see how it goes. All right.
Thank you very much, Dr. Edu Bonsafo and Dr. Bachman. And of course, thank you to our participants. We are a bit behind schedule, but you'd all agree with me, these are very pertinent questions that need to be addressed. We are rounding up, but we would like to have a very short exercise before we do. So on our screens, we would like to know where we are all joining from. And so quickly, we want us to go to www.menti.com, and then we use the code on our screen, and you type in where you are joining the second APEG Sports Study webinar from. We appreciate that you could join us from all over the country. And I think we have international participants as well. We'd like to know where you're joining us from. Oh, somebody's joining us from Kumasi. You're welcome. Thank you for joining us. The code is 4319459. You go to www.menti.com, and then you enter the code 4319459. We have participants from Kumasi and Accra. Thank you for coming. Mamprobi General Hospital, thank you for joining us. From Tamale, thank you for being a part of this webinar. Whole Teaching Hospital, we are glad you could make it. From Hacho, from Takwa, from Cape Coast, we've had 80 participants join us, and we'll be glad you could all. Jabuso Government Hospital, Brekum Holy Family, Apikenu, I hope I got that right, Adenta, from the Greater Accra Regional Hospital, thank you for joining us. From the Netherlands, thank you for being with us. From Tepa District Hospital. From Brekum, Mamobi, Salt Pond, Nadoli District Hospital, thank you for joining us. Esidem Hospital, Accra, we are glad you could join us. Kolebu Osu, Accra, SDA Hospital, thank you, thank you, thank you. AME Zion, Star of Hope, Sankore. Salaga, thank you for coming. Tepa. Eastern Region, Obuasi, Offenso. We are happy you could all be a part of this. Our next question, as a form of evaluation using the same code, is to describe your experience with this webinar in one word. How do you feel about this webinar? In one word. Educative, it's been great. These are your words. Thank you so very much. Informative, adequate, eye-opening, very insightful, in-depth, excellent. Thank you very much. And thank you to our speakers who has made this very excellent, very insightful, very educative, very informative, very eye-opening, as our participants are saying. It's been enlightening, very helpful, educational, motivative, updated. Thank you very much. So on behalf of the executive body of APEC Ghana and Sport Steady, would like to say a big thank you to our speakers and of course to the webinar organizing team. This has been very insightful, like you have said, and we are very, very grateful to our partners, to the organizing team, and of course to you, our cherished participants. We couldn't have had this webinar without you. We are glad you could join us from all across the country. Like I've indicated, the webinar is CPD accredited, and the links for registration is in the chat box, and you also receive that in the registration email. We also entreat you to follow us on our social media pages. We're on Facebook, we're on Twitter, we're on Instagram. Like, share, comment, and follow us. Tweet, we will retweet, and let's grow together. Thank you all once again, and we look forward to hosting you again soon. Our next webinar is on the 25th of September. The details will follow shortly. And so on this note, I say thank you to you all. Thank you for joining us. Huge thanks to Dr. Edu Bonsafo and Dr. Bachman, and of course to the Sports Steady team, Dr. Sofeyon, Dr. Joyce Brown, Dr. Klaj, and of course our Executive Director, Dr. Mrs. Koiwa Ofosuapia. Thank you all. And to our participants, thank you, thank you, thank you, thank you. See you all soon. It's bye for now.
Hello.